Welcome, welcome everyone. We have very talented list of speakers, panelists and advisors for this virtual side event during the 78th World Health Assembly, which started in Geneva, Switzerland on Monday, May 19th. Speakers' names, email addresses, and short bio of the speakers are available on the website. The link to access all this information is also available in the chat box. If you have any questions for the speakers, please feel free to contact them directly, but wait for the session to be over or write your questions in the chat box. We request the audience to keep your speakers and videos muted during the sessions so that you all can see the speakers and hear them properly. The title of today's side event is Health and Education, the Best Building Blocks for Sustainable Development. Our special focus is to improve maternal and child health, primary care, and universal health care. Let us get started. All right. Okay. Okay, good. Women's Health and Education Center, its acronym is WHEC, was established in 2001 to undertake initiatives with the United Nations, World Health Organization, and UNESCO. It is tirelessly working for more than the last two decades to improve global health with special focus on maternal and child health. The health and status of women is a very complex and a challenging issue for developing and industrialized countries alike. Women face enormous obstacles, prejudices, domestic violence, poverty, hunger, and virtually no access to medical care and life saving medicines in some developing countries and communities. The United States is a vast multicultural society, and providing quality care to diverse populations require much more than translating a foreign language. We should be willing to learn where each patient is coming from, taking into account how culture, customs, and community pressures affect her decision making and processes. Internet classrooms are the most cost effective way to provide basic education and continuing medical education to the developing countries. Knowledge and understanding are essential at all levels to make and implement good practices in education and health sector. This is our today's agenda: fostering societies where everyone is included. Both social justice and digital transformation can improve access to essential services for vulnerable communities, creating opportunities for everyone. Number two, expanding UNESCO chair program and promoting global collaboration. Fostering inclusive digital transformation, building the capacity to care, preparing the next generation of healthcare professionals in the international arena, deepening their knowledge and improving the skill set of a career in global health and global governance is urgently needed. The Women's Health and Education Center had launched an e learning project in association with the Department of Public Information of the United Nations Women's Health Section.com. Uh, and it is doing very well. Now it is serving in 227 countries and territories and provides the services to 14 to 15 million visitors every year with a special focus on maternal and child health. Information is provided in six official languages of the United Nations. Education and health are deeply intertwined. One sector helps to advance the other. Health for all and education for all are expressions of the UN commitment to health and education. Thanks to the UN Chronicle for publishing our views and initiatives. Improving maternal health through education, safe motherhood is a necessity. The link of this article has been provided to you, and we are grateful for the UN Chronicle for publishing it. Please read it at your own convenience. Developing countries and industrialized countries can both learn a great deal from each other's experiences with various social and healthcare projects and programs. Future of health and education sector is digital in every country. E-learning is most cost-effective way forward to tackle maternal mortality and morbidity in developing countries. To be able to read, write, and calculate has been acknowledged as a human right. However, more than 100 million children are still deprived of access to primary education, and fewer than half of all children worldwide participate in early childhood programs. Gender equality, including in education, is a condition for development. Preparing the next generation of healthcare providers in the international arena, deepening their knowledge, and improving the skill sets for career in global health and global governance is urgently needed. Programs are needed for healthcare providers to provide them with academic training and practical knowledge to assist them in providing national and international healthcare. We have the knowledge, means, motivation to act. Let us not wait a moment longer. Over the last 25 years, Women's Health and Education Center has been working with the UN system, WHO, UNESCO, and many academic institutions in the United States of America and abroad. We believe that empowering individuals, families, and communities is the way forward. Lessons learned and areas of future development are WHEC Global Health Line was launched on 4th July 2013, which is serving in 227 countries and territories, aims to disseminate reproductive health research and rights, how to balance these rights with the imperative that communities and societies will then be more likely to make reproductive choices. Now, of all the health statistics monitored by the World Health Organization, maternal mortality and morbidity, both physical and mental, shows the largest differences between the developed and developing country. Every day, at least 700 women and girls die, one every 2 minutes, due to complications of pregnancy and childbirth, and hundreds more have short and long term disabilities. 90% of these deaths and disabilities occur in the developing countries. And this is 2025. Final tips. Quality education and universal health coverage are the most important investment that any country can make for its future and for its people. Women's Health and Education Center is well positioned to advance all SDGs, Sustainable Developmental Goals, with special focus on 1, 2, 3, 4, 5, 16, and 17. Our Link Access project was launched to disseminate reproductive health information and research will offer way forward. LINK is an acronym for learning, innovating, networking for knowledge. Digital technologies, including artificial intelligence, AI, and big data management have the potential to eradicate poverty and reduce inequalities. Uh, by supporting reproductive health and research, and open dialogue and objective analysis, we have laid the groundwork for mutual understanding among countries. Please, at your convenience, review our partners and community voices. Their links are also included in this. Well, thank you very much, and I will hand over to the very talented speakers who have joined us. Click to exit. All right, where are we? Oh, okay, good. I didn't mess it up. That's great. Okay, now I hand over screen share as a shared window. Uh, Uh, I will hand over the floor to Dr. Colleen Kraft, Professor of Pediatrics and 2018 President of American Academy of Pediatrics. She is highlighting on preparing next generation in global health and global development. I can see Colleen's screen and she must be somewhere. Okay, Colleen, the floor is yours. Go ahead.
Thank you so much. For some reason, Zoom says that my camera is not on, but I can at least do the presentation here. So I'm going to talk a little bit about preparing our next generation of healthcare providers in global health. And what's interesting is that this is a huge interest in our training pediatricians right now because they're interested in advocacy in global health. They understand, and part of their training is now just not the medical stuff, but also the need to recognize and address social determinants of health during our clinical encounters. How do you do it all at the same time? And our leadership, the Accreditation Council for Graduate Medical Education, has now supported individualized track. So the requirements from the Accreditation Council for Graduate Medical Education now list a minimum of 40 weeks of an individual curriculum. And that individual curriculum has to be determined by the learning needs and career plans of each resident and needs to be guided by the program director or designee. And it can be distributed across the years of educational treatment. So what's important to know is that global health advocacy, addressing social determinants of health, new technologies like AI are all really part of what's being incorporated into clinical training. So the way that we do this in Los Angeles through our pediatric residency is in a track called Improving Medicine, Pediatricians and Communities Together. And what Impact does is it brings together our clinical training with core lectures in social determinants of health and understanding population health, understanding new technologies. And then the residents can actually choose to do either a community health track or a global health track. Well, why global health care? It really makes a lot of sense. I mean, we have kids who are coming to this country from everywhere, and to understand providing equitable health care, we need to be able to provide this regardless of the socioeconomic or geopolitical circumstances. We know that if you can do something for the poorest of all kids, you can enhance child health outcomes for everybody. And that if you don't understand health inequities, then you really are not going to be very effective in treating children. And so understanding and combating health inequities is something important. So in our global health track, we have learning modules that are aimed at providing a detailed summary of global health topics and opportunities. We have noon conferences with visiting professors. We had one yesterday with a professor who talked about neglected tropical diseases. Um, Curiously, a lot of these tropical diseases are coming back, things like dengue fever. We are seeing that in Los Angeles, so important to know. And then there's participation in a longitudinal scholarly project. What you're seeing here is a childcare center in Bukhara, Uzbekistan, where we are working with the preschool teachers and the medical system there in combating anemia in preschool age children. The curriculum content is really very wide. It goes through global burden of disease, child survival. One big thing about developing ethical and global partnerships, we've really gotten away from the idea of a mission trip just because that's really not good language, but we really what we want to do is develop ethical and global partnerships. We learn as much from our overseas partners, our global health partners, than as we bring and teach. Practical barriers to implementing global health, working in global health organizations, and then the basics on maternal and newborn health and diarrheal diseases and parasites and environmental health. Right now, we are very focused on child advocacy, particularly with some of the cuts to USAID and some of the funding that has been life-saving overseas. How do we tell our elected leaders about what the good is that these programs do and why they need to continue? We work with partnering with global health organizations. So one that we work with here in Los Angeles is called the Refugee Health Alliance. They have been quite important in terms of having the right type of medical care available for those who are coming across the U.S. southern border. And what we've seen in the last 5 years is that it's not just people from Central America, it's people from Haiti and Venezuela and Russia and Ukraine. So, Refugee Health Alliance has shelters. What we do to partner with them is that we go down to Tijuana on weekends and take care of some of the kids down there. There is something we learned to write called medical parole letters. These are for children who are very ill, who are coming across the border, who really need to be seen in a children's hospital. And we look at their medical chart and write those letters so those kids can get the right care. And then we have clinic partners where we work with these clinics in Tijuana. We're working specifically with the Resistencia en Salud, which is in Tijuana, and helping them develop the capacity to take care of children within that clinic. Some of our global local work, one of our other partners is Project Vietnam Foundation. They are located in Southern California as well too, and started after a number of people came from Vietnam 50 years ago, after the fall of Saigon. And what we have done is really work within the Vietnamese community to teach certain important topics. One of the big ones that we're working on is combating vaccine hesitancy. There's a lot of misinformation and hesitancy about some of the really important childhood vaccines. And so we work with the foundation to work with the Vietnamese community in Southern California. But at the same time, what we are doing is we're working in hospitals in Hanoi and Ho Chi Minh City and working on how they do their pediatric well care and pediatric promotion. And specifically, we're working with schools and teachers and clinicians about the diagnosis and management of autism. We have a group who are going over there in September to be doing some training of teachers, but also of parents on how to manage children's behavior who have autism. Some of our academic partners are important as well too. So in Uzbekistan, in Bukhara, we work with the Abu Ali Ibn Sina Medical Center and look again at building pediatric capacity there. The Essential Newborn Care One training for nurses has been important in that there has never been simulation training in Buhara for nurses. And so nurses would go from their classrooms to the hospital and not really have a good idea about what to do with patients. And so this has been something where we've worked with the nurses within the delivery rooms. And what our trainees are doing are now virtual refresher trainings with the nurses that are there. So they're getting on Zoom once a month and going through skills on resuscitation and using an ambu bag and some of those other skills. And it really has been something that's been very helpful. And then I showed the slide earlier about the preschools. What one of our doctors over there found was that about a third of all preschoolers in Uzbekistan, in Bukhara, are anemic. And so we are looking at finding the reasons why and implementing a number of different interventions, one of them being in the preschools itself, teaching what's healthy food, what's not healthy food. But we also have programs looking at giving iron to those kids who are anemic and then checking for helminths and deworming these kids to prevent anemia. We have advocacy for special programs. I mentioned that because of a lot of the global funding cuts, we have had to really step up our work here. USAID used to run a domestic violence shelter for women and children, and that shelter is still running, and they have some local support for it. But an example of something that was a really wonderful program that is now scrambling because of some of the decisions that have been made at the United States level, and that USAID is such an important program, and that we talk with our local legislators about how important it is and why the funding has really been something that's been terrible for children around the world. And I talked a little bit about legislative advocacy. We learned specifically how to do this as well too. There is a public health curriculum and then community-based participatory research skills didactics. But we go to Sacramento every year, and we have some residents that go to Washington, D.C. every year as well too, to speak with their elected leaders because children don't speak for themselves. They need adults to speak for them. So we talk about what we're seeing in social determinants of health. We're talking about why funding for programs like Medicaid and for SNAP and for so many just very basic life-saving programs are so important here, but why USAID is something that is so life-saving for children overseas as well too. And that advocacy is very important, and we have to keep the pressure up and keep our voice ongoing. Teaching our younger pediatricians and our trainees how to do this as part of how you care for children is something that is ongoing, something that is important, and something that's going to build our future. And with that, I'll say thank you.
Well, we couldn't see you, Colleen, but this was very impressive. Maybe you can check back and I'll admit you again. Maybe the camera will start working for you. And where did Frank go from his desk? Hello, Frank. Good. Well, you can turn your microphone on.
One moment. Perfect.
Oh, okay. Now is Dr. Frank Shermanek, Professor of Obstetrics and Gynecology, Associate Dean for International Medicine, Zucker School of Medicine at Hofstra, Northwell, New York, New York. Ethics is his favorite subject, and he will highlight the ethical framework for obstetricians and gynecologists. Go ahead, Frank.
Rita, I thank you. It's a pleasure to be with you in this wonderful panel. And I'm going to talk today about an ethical subject, and it's a challenging one. Here in the United States and in my travels throughout the world as well, it's the subject of zealotry. First, let me say that for centuries, medicine was a guild. Medicine's goal was to make money. It wasn't until a great physician ethicist in 18th century Great Britain, John Gregory, formulated the concept of physician is a professional, where a physician should become and remain scientifically, ethically, and clinically competent, protect and promote the health-related interest of the patient is the primary concern. Making money is fine, but it must be secondary, and preserve and strengthen medicine is a public trust. I love this image. I'm proud to be in the Royal College of OBGYN in Great Britain. On one side, in the blue, you see physicians had scientific excellence. They saved mothers' lives with the Chamberlain forceps when cesarean delivery was a death sentence. Not enough. It was melded with the compassion and the virtues of a midwife. And I'd argue it's the same today. This is what ideal physicians are. You need scientific excellence melded with the virtues. Now, I need to go quickly because the time is short and I want to respect the program. But we need to navigate competing interest, cultural competence, reproductive ethics, and professional boundaries. Now, the topic I want to discuss is zealotry. What is zealotry? It's fanatical and uncompromising pursuit of religious or political or other ideals. Now, this imposes personal values on patients rather than facilitating informed choice. And where does this come from? This comes from ancient Jerusalem. And let me show some pictures to illustrate this. The Zealots were a first century Jewish movement, and they advocated rebellion against Rome. And this is not why history condemns them. A lot of people were against the Romans. We had in Germany and France and Great Britain, and initially the Zealots had some success. The problem was eventually Rome defeated the Zealots, and the Zealots made a decision. It was better for them to kill their fellow Jews, to kill the moderates, to burn the food stores, and this was a disaster. The Talmud teaches us that Jerusalem at this time was one of the most beautiful cities in the ancient world. This was the result of Herod the Great. He was a builder, and the Zealots preferred that the temple be destroyed rather than acquiesce to the Romans. And for this reason, the Zealots are condemned in history. Let's move forward a little over 1,000 years. Pope Urban II called for the Crusades, holy wars, to throw Islam out of the Holy Land. This was a disaster. It was totally unholy. Millions upon millions of Christians, Muslims, and Jews were slaughtered. They estimate up to 5% of the world's population. Didn't accomplish anything. This was very, very unholy. Please, I can give many examples. The 30 Years' War, 500 years later, they called it the 30 Years' War because it lasted 30 years in Germany. It's estimated about 50% of the population of Germany was destroyed for a pointless war between Catholics and Protestant. Again, this was all ridiculous. The point I'm making is that all these religious wars accomplished nothing. Now, how this is relevant today in the United States and throughout the world, this happens today regarding abortion. People searching for abortion online are often fed misinformation on the web and in person. And you can see here such information that everyone has access to. Now, Zealots have influenced abortion care, IVF infertility treatments, even contraception, OB emergencies, gender-affirming care, and even research. This influences and is detrimental in so many areas. In Alabama, it actually put a pause on IVF. Now, Southern Baptists are the largest Protestant group in the United States. Please, everyone is entitled to their own religion, but this can be used as a tremendous political force. Now, it's the ethical responsibility of us to respond to zealotry. Let's go back to John Gregory. This calls for all of us to subordinate self-interest to patient welfare. It's our duty to advocate for evidence-based standards against ideological interference and counter misinformation. I was delighted to see the new Pope says the future of the church depends on greater inclusion and nuance on reproductive health issues such as abortion, contraception, and IVF. So there's the potential for relooking at some of these issues. Now, why am I making this point? I love history, but this has real relevance in the United States, and not just in the United States, in my travels around the world. All of you know that the Supreme Court overturned Roe v. Wade, and there's a whole hodgepodge of laws in the United States. And this is unbelievable, with many, many exceptions in different states. Some states have exceptions for rape and incest, for health, for this one is for incest, this is for fetal anomalies. Bear with me. As I said, I love history and ethics. I want to relate something by Marcus Tullius Cicero. He was brilliant. He was brilliant. He posited a concept of universal law that is echoed through the centuries of legal and ethical discourse. This is important. And he made a distinction between jus civile, or civil law, and jus gentium. Bear with me a moment. Jus gentium, or the law of nations, protects fundamental human rights across state borders, preventing unequal access to care, and avoids this problematic patchwork of state laws that force medical travel and create healthcare deserts. Our current president was very proud, saying he turned the law over to the states. I say this is ridiculous. I am no different, and New Yorkers are no different from our colleagues in Florida and Texas. I would argue that Cicero's comment of jus gentium, or law of the nations, applies. Now, why is this important? Why is this a clinical ethical issue? We know from our history in the United States that maternal death plummeted once law was liberalized. This was before my time. I heard stories from my teachers of women who came to the emergency room who died or had septic uteri. And already we're beginning to see mothers dying today because of lack of access. And these are some cases that are surfacing. A colleague in Texas sent this to me. This is Jessica Barnea, another teenager who died after trying to get care in 3 visits to Texas emergency rooms. And this is one, she also died. Again, doctors are scared because they don't know what they can do and not do. Abortion bans have delayed emergent medical care. In Georgia, experts say this mother's death was preventable. So we're going to see more and more of this happening. Now, my friend Arul Kumaran, a great doctor, he had success in Ireland. Savita was a dentist who died unnecessarily because she had ruptured membranes and sepsis. She couldn't get an abortion in Ireland. And Arul Kumaran led the charge to overturn the laws in Ireland. So, I mean, I hate to say it, it's going to take more deaths for this to happen in the United States. I'm going to go quickly because I want to stay on time and respect the program. But I want to introduce another concept. We have another big embarrassment in the United States, the racial gap in deaths among US moms about the time of childbirth. And this current problem with abortion is going to affect Black women more than white women. So this is going to accentuate this racial gap. James Madison is one of my heroes, and he said it so beautifully. Religion and government will both exist in greater purity the less they are mixed together. I want to make it clear. I support religion. I personally have a religious belief, but we can't force our religion on anyone else. And I emphasize this strongly. I defend religion, but we can't force it on anyone else. This goes back to the Enlightenment. We don't have time to go into the great thinkers of the Enlightenment. We need an inclusive OBGYN ethical framework that respects diverse viewpoints preserving professional integrity, a global perspective, adaptive professionalism, and educational imperatives. There's so much more I could say, but Rita, I want to honor the program, stay on track, and limit this to 15 minutes. Let me stop at this point, and we can have question and answers later, and anyone is free to email me and continue the dialogue. Thank you for the pleasure of being with you this morning.
Wow, thank you, Frank. Everybody is on time. I'm very impressed. Okay, now I have three very talented professors. First is Dr. Vanity Gopalakrishnan, Associate Professor of Biomedical, University of Pittsburgh. Then is Dr. Edith Luhanga, Assistant Research Professor, Carnegie Mellon University, Rwanda, Africa. And I will allow you. And Dr. Ganesh Mani, Carnegie Mellon University, Pennsylvania, USA, will speak on our efforts in India and Africa to improve health and education. Go ahead. Who's starting? Yeah, go ahead.
Yeah, thank you, Rita, and the Women's Health and Education Center for inviting me to present at this United Nations Foundation World Health Assembly side event. Good morning, esteemed colleagues and delegates. Vanati Gopalakrishnan, and I'm a tenured professor in the Department of Biomedical Informatics at the University of Pittsburgh, with secondary appointments in bioengineering and clinical and translational science. I direct the probe laboratory for pattern recognition from biomedical evidence, and I'm the founding director of the Pitt Vihar Center. It is an honor to share the vision and progress of the Vijayalakshmi Innovation Center in Women's Health Analytics and Research, VIHAR. At VIHAR, our mission is clear, which is to conduct world-class research and training that empowers women and girls across the globe to take charge of their own health and well-being. We aim to do this through the strategic integration of healthcare technology and artificial intelligence. Our vision is ambitious yet essential to become the world's premier innovation center for evidence-based integrated women's health and wellness across the lifespan. This vision is supported by philanthropic partnerships and a growing global network of collaborators. We are proud to be building a global innovation center that addresses a critical gap. Despite making up nearly half the global population, women still face inequities in healthcare, access, and outcomes. Our center seeks to change that through integrative modeling of multimodal health data, from genomics and wearables to clinical records and conversational AI. Our research priorities include developing digital twins for women's health, simulating female-specific organ systems, starting with the placenta, which is the first organ to form before new life can be supported, applying multimodal large language models to clinical scenarios, such as, for example, simulating postpartum hemorrhage contexts digitally for precision care everywhere, discovering biomarkers through multi-omics for precision medicine, and creating real-time data frameworks for personalized care. We're also deeply committed to education and capacity building. Through partnerships like Climb and Thai Global, which is a nonprofit for advancing entrepreneurship across the globe, we are mentoring the next generation of innovators, including high school students, by engaging them in real-world AI and biotechnology projects. Our global partnerships are central to our mission. We are proud to lead the proposed UNESCO chair in global partnerships for digital health and lifelong education, collaborating with institutions like CMU Africa, Southern California's Children's Hospital of Los Angeles, and the NGOs such as the WHEC. This initiative reaches over 220 countries, as Rita Luthra said, and supports over 30,000 courses serving underserved communities through digital health education. We also work with partners such as TIP Global Health on projects like EHAZA and maternal initiatives, the childhood stenting project in Rwanda. Supposed to work with the nation on research into the intersection of microplastics, stress, and maternal health. Our work is focused on preventative and proactive health, and upon examining the recent statistics on the WHO website for India using AI and humans, a man-machine collaboration, if you will, we noticed that India still has hypertension and COPD as big issues. India has several positive health trends ongoing on the maternal and child health areas. A pressing issue that we are planning to address are the NTDs or neural tube defects. Their prevalence in India is almost 10 times that of other countries like Europe or US. Despite existing WHO guidelines recommending folic acid supplementation before conception, implementation gaps persist. So there is a missed timing where most women first take folic acid after organogenesis, while they should be starting much sooner. So our analysis highlights missed opportunities in preconception care, low adherence to supplementation, and limited awareness. We propose actionable solutions from fortified food distribution to digital health interventions and public awareness campaigns. In closing, Vihar is more than a research center, it is a movement to harness the power of AI, data, and global collaboration to transform the future of women's health. Together, we can close the equity gap and ensure that every woman everywhere has the tools and knowledge to thrive. The University of Pittsburgh, or PIT, will be hosting a global forum to forge this future in October. And I will leave you with an aha moment to develop and use algorithms for healthy aging as an approach that aligns with the United Nations Sustainable Developmental Goals, suggesting that health interventions should respect local lifestyles and environmental factors. And thank you. I'll pass it on to my colleague, Dr. Ganesh Mani.
Am I going next or is it Edith?
Yeah.
Okay, happy to go next. Thanks for having us here, Rita. So
Yes.
real quickly, I'm here in Pittsburgh as part of Carnegie Mellon. I'll go through these things quickly. The United Nations Foundation has put this up, and I'll put the links in the chat, 5 global issues to watch. Some of it are beyond our control, right? So wars,
Yes.
many of them going around the world, financing for development, investing in a sustainable future. Clearly, there's a role for AI and data, climate action, a lot of application for AI and data, gender equality, of course, theme near and dear to Dr. Luthra's heart. And then they're also talking about reforming the institution, right? So those are, again, processes, diplomatic things, which could be very useful. Now, let me sort of segue back to where we are. Obviously, there is a digital divide. You need to be able to get people to connect efficiently before you can do AI and data. It's not just how many people can access the internet, what's the speed, what devices they are using, and so on. Clearly, there's global health inequity as well. There are countries in the West that have better healthcare systems in some sense. Like in the US, the tertiary healthcare system is good, but the costs are very high, right? So we had put together a set of challenges for the 2020s when we wrote sort of the AI Grand Challenges article around health, wealth, and wisdom. How are some things that can be improved in nursing homes? What are some information-related challenges? Again, folks can look at this in the AI magazine. Any data science or AI project is a triad. It's data, could be traditional data, alternative data, domain knowledge, except you need to make sure it's the right person giving you advice. So there are talent and trust implications. Tools, now they're getting open sourced, widely available, not necessarily, especially if it's software, but subject to tariffs and geographical boundaries. So we wrote this article about Made in India AI around the previous tariff administration several years ago, quite germane because data and domain knowledge tends to be regional. Sometimes you have to take compute to the data as opposed to moving the data. It's Morgan or the Muhammad, right? These are some very interesting use cases: machine learning, natural language processing for precision agriculture, chatbots for education, um, generative AI. How can you create content for education, but also for health, right? There is a clinician and patient encounter, then different views of that same encounter needs to be given to a caregiver, given to the doctor, given to the insurance company, and so on. McKinsey has put together 5 promising applications for AI, globally competitive value chains. They talk about in East Asian city, I don't know, maybe Guangzhou perhaps, using analytics models to identify untapped areas of economic competitiveness, um, how to attract investment for the right trade support programs, future work programs. Future work is big. Some work can be done remotely, some cannot be, like nursing, some things in the grocery store and all that, right? Somebody needs to actually stock the shelves and so on. This nowcasting and forecasting. Census sometimes is held every 10 years, sometimes not held for decades. Transforming public services. That's a nice segue to a lightweight collaborator of mine who has guest lectured in my class. We, Mevanti and I, are headed to CMU Africa early June. We'll probably have a meeting with Emily Eichen. So she wrote a paper around using nowcasting, so remote sensing plus metaphone data, metadata from phones for dispersing aid in Togo using mobile money and so on. So that's a very interesting application. So there are some very interesting applications combining remote sensing, smartphone data, other data in terms of fulfilling some of the UN SDGs. But we still have data inequalities. Now, if it's text, there it's pretty much very mature in the Western world, and China and India a little bit. Speech and video slightly more available in the sense the Gini coefficient is lower because everybody can create videos these days. TikTok is sort of helping, but then you have to look at the veracity of information, right? AI optimism, um, even though the data inequalities are worse in some of the emerging economies, the AI optimism actually is higher there. So at the bottom here is things like the US at 30-40%. But just above that are a couple of emerging economies: Turkey, Thailand. Thailand's a positive outlier in terms of optimism, likewise Indonesia, China, etc. So they are starting to believe in the magical powers of AI, if you will. But if you think it can solve some of the hard problems, then it may actually disappoint you. That was the conclusion from that Kenyan study where it was available to entrepreneurs. Entrepreneurs who weren't that skilled were using it for very challenging tasks and so on. This is some financial inclusion project at CMU Africa. Actually, Edith and her team has done bulk of the work. But we have 2 or 3 pillars there. So I'm a collaborator developing recommendations for digital financial literacy strategies. Health, which is sort of the topic of today's session, primarily second opinion in the US. It could even be the primary opinion, right? If a doctor is not available, can you just use the machine to proxy as a first opinion? So we've done some work with a mammography company from the early days, Second Reader. It became a small public company called ICAD. Both Vanti and I were involved in it. It's being acquired by RadNet, now one of the largest radiology providers. This is a tongue-in-cheek view. The line saying, I still have room for a second opinion there. What are some interesting research projects I personally have been involved in? Collective intelligence. Can you elicit opinions from hundreds of people using a combination of breakout rooms, if you will, and an LLM? eavesdropping on each room and conveying key information across rooms. Those are the yellow lines there. Low resource languages in Africa, how do you sort of tackle them? If the data is poor, it's all still garbage in, garbage out, right? Data is poor, your insights are going to be poor. So what are some policy recommendations? It's fund open source AI toolkits, encourage public-private partnerships, global AI equity standards so that we can move things across geographical boundaries, co-design so there are no trust and access issues. People were talking about ethical considerations. So responsible AI is a big field in itself, but there's no consensus on what constitutes fairness, transparency, accountability, etc. So a lot of work to be done. And we've got to ensure that AI is a catalyst, not a divider with that. Let me hand the virtual microphone over to Professor Luhanga. Over to you, Edith.
Yeah.
Thank you, Ganesh. And thank you, Rita and the Women's Health and Education Center for inviting us to this talk. So I'll continue some of the discussions around healthcare and the way we're using AI with my research group to promote maternal health literacy. So a variety of studies, some of them highlighted here, show us that when women have more knowledge about health, they're more likely to notice danger signs and seek care on time, but they're also more likely to attend antenatal clinics where they can have preventative services offered to them. And with more and more people adopting digital technologies, we're seeing initiatives like Mom Connect in South Africa, which was launched in 2014. This started as a SMS-based service providing weekly messages on pregnancy and reminders for antenatal care visits, but it's now spanned into a help desk that is partly managed by AI. And since its launch, it's been a self-sign-up service. It's more than about 5 million users have come on board, and they've really had an impact in the number of antenatal care visits that pregnant women have. And there's a demand as well for the help desk feature. In 2018, there were about 250 messages per day received. But so this is just South Africa. What about digital technologies and how they're supporting maternal health in other African countries? That was the focus of my initial research. So starting in 2021, we've been looking at surveys as well as desk research to identify the scope of available apps and maternal health information on the internet in different languages. In a survey with about 182 women in Tanzania, we realized that most women, when they seek information online, they're really trying to get clarity on the symptoms they're experiencing. But when you do look for those symptoms, most of them go to search sites like Google. The information they get back is mostly peer-created content, so it has limited credibility. And so they often move to Western-created resources, like websites like Baby Center and What to Expect When You're Expecting. But here they encounter a different challenge. Some of the concepts or examples used are not always familiar. Some of the language used as well is what they would term complex English, because English is not most women's native language in Tanzania. And overall, sometimes there was a feeling that the information can be ambiguous. So especially when looking at articles describing symptoms, what does it mean to, let's say, have more than slight swelling? And how do I take this information about what foods I should be eating now and make it actionable to have better nutrition during pregnancy? We did a desk review of Rwandan websites and apps, and we found 0 apps around maternal health, over 2,000 web pages on maternal health from 69 websites, but only 5 of these websites were health websites. The rest were mostly online lifestyle magazines. And although we did find quite a few important topics, 5 of them to be exact, most of the topics, as you can see in this graph, focused on the importance of consulting with a doctor. The other topics were covered most usually by less than 50% of the articles, and they were very short, so it was not really actionable information. So what am I doing now? Well, inspired by the fact that the help desk was a very popular feature on Mom Connect, but also the fact that when women go to antenatal care clinics, they're really engaging in conversation with healthcare providers. We're seeking to look at how effective is it when you provide conversational features in maternal health apps. Now, chatbots have been used in various studies already on maternal health. So what is different with our approach? Well, first, we're using an avatar-based chatbot that is not just looking at what women are asking. So it's not just question answering, but it's also looking at what women are using in terms of what are the symptoms they're tracking, what are the other factors they're tracking, their weight, their nutrition, what are the articles they're reading within the app. And we're using this data to prompt conversations that will guide on reflection and also lead them to action planning. And so the two main questions, as I mentioned, is what conversational prompts are most engaging to guide women to reflect and then plan actions for behavior change? But then how effective are some of these conversations overall? Is it worth it putting all this money in developing conversational AI, or would we get the same benefits if we used other approaches that are not necessarily digital? But as we've been developing these prototypes, we found we needed to answer a lot of interesting questions, and we'll be publishing some of our findings pretty soon. So, for example, we've been looking online to look at when do women engage in conversations around pregnancy with other women? So, when are they seeking advice? Are they seeking information? What about? And which posts get the most responses, or which kind of people get the most responses? And we're using this to really guide how we will develop our avatar-based chatbot. But we've also been looking at large language models in themselves. Yes, they're good at conversation, but which ones most mimic the types of conversations women have online? And which ones are best at sustaining these conversations, not just in English, but in the various local languages? And finally, as Ganesh pointed out, digital device is still a reality. So when we are designing these tools, for most users with low digital literacy, it can be daunting to interact with a chatbot when you don't really understand what that chatbot is and how it functions. And so we're looking at how do we design so that it's less daunting for users with lower digital literacy, but also in the event where users do not have a personal device, how do we design for privacy so that even when they are sharing a device with somebody else, they can still get the benefits of these personalized conversational prompts? So I'll end there. I'm happy to connect with anybody who would like to have more information. Thank you very much. Back to you, Rita.
Thank you, guys. It was wonderful, delightful. And I see two lovely ladies. They both are NGO representatives at the United Nations from Women's Health and Education Center, Miss Upasna Chauhan and Miss Lucky Gill. And they have a remarkable work going on in India, ending child marriages in India. So go ahead. Who wants to go first, Upasna? I,
So I'm
where is
sorry.
Lucky? She
Yeah,
was
Lucky
here.
was here. Yes, I'm really sorry. Hi, everybody. I have another very important meeting I cannot avoid at 11. I can come back at 11:10, 15. I just need 10 minutes, but is that okay, Lucky, if you can take over for 10 minutes and I'll be back?
Go ahead. One of you better start. Don't waste time.
Mm,
Yeah. Where is Lucky? I can't see her.
no, I think she can only do audio.
Or she can do audio. Okay.
Okay, no problem. I think Lucky is busy. I'm sorry, then I'll wrap it up in 5 minutes because I
Okay.
think she's
That's fine.
because I have to run. I'm really sorry for that. But I'll keep it very short and quick and just adding few angles. And I think what Varnati mentioned have really amazing points, especially from Indian angle. And I work with a lot of grassroots NGOs and organizations in India with very young girls who are not much aware about forget about digital literacy. They are that's the sector that I work with, who are right now learning basic education as well and dropping out of basic education as well. Unfortunately, that part is also there still today. And I think that's why we need to make sure that we do not miss out or exclude anybody and make sure that we reach to everybody. Another angle that I would like to really make sure about here is when we talk about AI and all these amazing opportunities, I think the most part we need to understand is the gap between where we are talking from and the part of sector of women and girls who we need to reach and make sure we include them. AI is very new to all of us. We are all educated. I am in technology and IT since many years. Even it's so new to me as well. But we need to go back and empower women and make them aware about a lot of basic technology first, the bad and the good sides of AI, including because at smaller places in the smaller villages and towns, the awareness about AI and the negative impacts of it is completely unaware, especially for young girls and women. They have no idea how their pictures, how their data, and how their banking data can be, there are so many scams that are going on. So I feel like it needs to be multi-angle, like Ganesh said. It needs to be collaborative. The policymakers needs to include the uh, women and girls from every sector, and not just the ones who are in the educational sector or in the private sector. It's basically needs to be collaborative effort by everybody. And I feel like we always think that, okay, no, we need to have a certain set of women only who can be part of it, but that's not true. We should include everybody in this process, because right now we are in the beginning of the process. So I feel that's for now. I'm really sorry, I have to jump out, and I'll be back in 10 minutes. And I'll leave the floor to Lucky or you guys to discuss. I really, really apologize for
Okay,
this.
is Lucky starting? Go ahead. Tell Lucky to start.
Lucky, maybe you can take over. I'm sorry, I have to switch off the video also. I'll be back in 10 minutes.
Can
Hello,
you guys
Lucky.
hear me?
Yes, we can hear you.
Yes, and my sentiments are same as it goes with Upasana. I actually just came back from India. I had 2 trips back to back. One reason I can't go on video, I actually caught some sort of virus and was sick. I actually interacted with some women. I did visit a local school, and the issues are same. We do think that as I'm listening to the AI and all the technology taking over, but when we do go to the rural sectors, they're very far away from all this, and they still need a lot of basic necessities. Basic needs haven't even met. And I sat down with some young girls, and we were going over some period education, and the education is not there. Some were not even aware of the pads. They were still working on cloths, and which to me was absurd. And then this other day I was walking by, and I saw these women just hiding and burning the cloths that they were using for periods. So the education, the lack and the gap is huge. At sometimes it looks like we are, you know, everything's progressing, everything is, is very, everybody's aware. I just assume sometimes that everybody knows about the and all everything that's available out there, but no, that's not the case. And I think the education at the rural areas and where it needs to reach, the outreach is not there. So I do see the big gap out there. So that was my thing that I noticed.
Thank you, Lucky and Upasana, for giving that information. So I had a quick question for you. Do you have people who come from cities and from other areas, other schools, to talk to the rural people? Are there any outreach activities that are in cities
Um,
established for, the rural communities?
the 3 villages that I was in, and I actually sat down with the women. I sat down with my sister-in-law, and I was talking to the children. So there were 2 school of thoughts. Like there's people that are in, especially in my village, they're not even sending their kids to the government schools, which are, you know, basically free education. And that's where we see the big gap, and everybody is kind of in a rush to send their kids to the English medium school so kids learn English and all that. And I was very happy to see one thing there, that they had the sex ed there, which I was like, I mean, it's not as progressive as here, like they don't tell everything. But my little niece, she actually knew what periods were. Because that topic is in her school, but that school is from Delhi School Board, so they actually started including it. However, parents are opting out; they don't want kids to learn that. But when it comes to the village level, when I visited the 2 other schools, that one which is my school, another one was from a village where there is orphanage that I work with. No, there is nothing that comes. Nobody comes from. There's no outreach. I mean, I want to connect them to somebody. So at least even if we can reach out to some of them, if you guys have anybody that would be interested, I can connect us, and maybe we can arrange some sort of Zoom meetings, or maybe arrange a TV or some, I can encourage them to learn. That's something that I saw that no. So answer to your question, in where it's most needed, it's not there. And I did not see organizations coming or anybody that's outreaching to them. No.
Excellent. Thank you. Yeah, that's very helpful to know. One last question for you is, are there any topics in school that are a must, like a core topic, such as health? In the olden days, we used to have things like home science, other things which eventually went away. But all of these things can now be included into the single topic of health in multiple ways. So, is there anything quite like that?
Again, it went to two different type of schools that I visited. No, it's not there.
Okay.
Yeah.
Thank you. Thank you.
I would be
Yeah,
more than happy to connect with you, please. And if you have shown interest, and please let me know how I can support, and where we can, make
super.
change.
Yeah. Thank you so much.
No
Yeah.
problem. Thank
Yeah.
you.
Thanks,
Thank
Rita.
you,
Yeah.
Rita. Thank you for the opportunity. Yeah.
Well, if nobody has a question, I have a question for you, Frank. Ireland, which is the real Irish religious Catholic country, could change the abortion laws in 2018. I'm not talking about 1,000 years ago, it's just a few years ago. Why can't America, which is so more advanced, and American College of OBGYN, which has a lot more power and teeth into this legislative process, can do anything, and we are still miserable after 5 years of this hodgepodge?
There's been incremental progress. Let me put it this way. Many, many states have turned the law toward liberalization. The problem is that these legislatures and it goes back to ethics. They're
Yes.
fundamentalist people who want to impose their morality on the population. And I can't emphasize enough, everyone is entitled not to have an abortion. As you know, Rita, for years I've written about how to counsel patients.
Yeah.
And you never recommend an abortion. You provide it as an option, but you can't force your morality on anyone else. Rita, it's a difficult problem. This is not ethics, it's politics. It's
Yes.
raw politics that people are using this issue. And I believe in incremental change. And I believe it's going in the right direction. I hate to say it, it's going to take more deaths. It took a very visible death in Ireland, the Dr. Savita case.
Yeah.
And already I showed some pictures of
Yes.
women who were dying. I hate to say it, it's going to take some pictures of wealthy women who die in Texas and Florida. It's sad, Rita. It's truly sad that we're in this horrible situation. I never thought we'd be there, but little by little, truth surfaces, and I believe it will go forward.
Yeah. Well, keep trying, Frank.
All of us
Yes.
are trying. It's funny, among doctors, I travel a lot in academic meetings, there's uniformity, and everyone believes that this is the way we must go. Not that people do abortions, but at
No.
least people have access to abortion.
Access, yeah, it's always a question of access, definitely. Luckily, I'm from Massachusetts, and our law never changed.
Yes.
Even though it's a Catholic state, whatever is so-called, whatever, very conservative state.
In New York State, the same way. But
Okay,
we're
oh,
no
really?
longer a United States, we're a divided states, as I showed
Yes.
by those slides, and politicians are playing. Rita, I don't have easy answers. I don't have easy answers
I know.
other than all of us need to speak up and do the little bit of good we can. And I truly believe it. All of us need to do whatever good we can on this issue.
Absolutely.
Can I ask a question to the
Sure.
panel? Can I ask a question? How much has everything that's been in the news in the past 2 months from our president, with, I think it's fair to say, an anti-globalist perspective, has this hurt the wonderful efforts that you're doing? I've listened to your presentations. Is this hurting your efforts?
No, not as far as I'm concerned. My this launch was private sector, and I'm glad I kept it for in the private sector because I had done a lot of research in the what does this private sector, the government sector means, all that stuff in the money wise. Eventually, everything is money anyway. Where is this money coming from? It's money coming from a trust. My parents had left it for me, and I'm using it wisely. That's all it is to it. Government gives you the maximum $5,000, and in exchange, you literally give your heart and soul for it. You follow their good rules and bad rules both, which is so much of little money and so much to give it back. I never went in that direction. So it stayed in private sector. So I don't take money from the government. That's all. 5,000 I can muster myself. I mean, that's good. It's going for the good cause. So
Rita, well done. Well done.
this will stay. Everybody says, why don't you apply for these grants? I said, grants are total waste of time and money or whatever it is. Nobody gives you the grant. Either they give you the loan and then they give it back to you, whatever it is. So whatever I can spend it to continue this, it will stay in private sector. So it doesn't bother me what Washington, D.C. does or does not do, because the money is a hard-earned money in a trust. I am the sole owner of it, and eventually it goes to a university after my death anyway. So it will stay in private sector. So it doesn't bother me.
Well done, Rita. Well
Yeah.
done.
Okay, looks like Upasana is back. You want to, we still have 4 or 5 minutes. Go ahead, Upasana.
Yeah, sorry. It was something urgent. I had to go
Okay,
back.
go ahead. They love to see those pictures, I know.
Yes. Let me quickly. I hope this time I can share my.
This was really eye-opener. Even though I'm from India for 10 generations and I was there till 25 years of my age, I didn't think people are getting their 5-year-old kid getting married in India. And India is the highest, unfortunately. Believe it or not, Frank, it's shameful. It's absolutely shameful. I
Okay.
met her in New York at UN one of the trips, and she showed me all this stuff. I said, "Really? What happened here?"
Yes. Let me.
Rita, we do the little bit of good we can, all of us.
That's right.
I truly believe that.
That's right.
Somehow, again, I'm not able to share my screen. I can share the presentation with you, Rita. You can open it up, or
Oh,
I'm
no,
trying.
you open or give it to Ganesh. I don't do the electronics.
It's somehow it always somehow there are some settings which is it asks me and it doesn't let me turn those also on, and it's very weird. It's
You can even just drop it in chat. If you just pick up your file and drop it in
correct,
chat,
correct.
one
Let
of
me
us
do
can
that.
do that. Yeah.
Thank you so much.
Because everybody else's worked very well and mine worked well. So setting from this side is okay.
Okay. Let me quickly see. The file is really old. Please ignore the title. Let me quickly attach the.
You just have to click on the file little
Yes, I'm
file button
I
at the bottom of the chat, like three
yeah.
things. So next to the smiley face or
Yes,
there's a file
actually,
button.
it's not supported file format. Oh God.
Oh, I see. Okay.
Um,
Can you
so
save it as a PDF or anything?
that's what it is actually. It is a PDF, but let me try. Oh, you know what?
Upasana, you want to drop it to my WhatsApp maybe? Let me see.
Huh. Or you have that, it's the same file.
I'm on my phone.
On 1 second, I'll email you quickly if you can share it. I just emailed you. You can open it up if you can. Thanks, Lucky. Yeah, it's not supporting the format. I'm sorry, guys.
We can email it to the panel after.
Yeah.
We have everybody's email. We can do that.
Yeah, thank you.
Yes, I think instead of wasting everybody's time,
let's email
you guys later as well, but I can definitely walk you through some of the basic details of what we were discussing and what Rita was saying is, and I'll share the file with you later. But
Okay.
the point here is that what we were discussing with Rita and like others already might know about is there are a lot of differences in when we just to give my background. I work with nonprofits in India, Bangladesh, Kenya, and US as well. I'm also UN representative for another organization called Man Up Campaign, where we work with young men and boys. And we want to encourage young men and boys to be an active part of gender equality, because we have reached a point where we are empowering women. The girls are empowered, the women are also empowered, but the men are nowhere closer to be found. And it's really like the policy drafting, all the main tables in the world, the policies are being drafted by men for women. So there is a big gap there as well. And all the events and conferences and the policy meetings that you attend, it's really just women. If it's about women's rights, it's women talking about women to women. And the men are nowhere in the picture, but the men are the main policymakers around the globe. So the goal for Man Up campaign is also to include more men in these conversations, and especially young boys and men, because that's where it all begins from. So we do work a lot of with a lot of organizations at grassroots as well, and also at the policy level as well in several countries. And so, for example, in Mexico right now, we are working with another young people who are working with the Chamber of Commerce in Mexico City and Puebla, in participation with the congressmen in Mexico, where the youths are drafting the suggestions and policy recommendations for the senators. And then we host a Senate meeting in Mexico Senate, and we recommend the youth recommendations, policy recommendations to the senators. Now, when we recommend these policies, it's all good, but when it comes to implementation, that's where the real challenge is. And because we do not have the funds, or the other, we do not have young men included, we do not have the funds, or women also included. So we are trying to bridge the gap from multiple angles. And coming back to how all of us can contribute from wherever we are is really the point. I think the best part of what we have understood is we have been able to bridge that gap because of today's technology. We are able to do this because of technology. We are still being able to touch with young people in different countries. However, we cannot forget the fact that there are a lot of young girls and women for whom we are making these policies. Those policies are not being implemented, including the child marriage, for example, as a basic law, which we are discussing about this since many ages and years. And we have to also address, it's not just a developing country issue, it's a developed country issue as well. It's as much as a problem in US, in cities like New York City as well. And it's just that it's not too much in media, and it's not as the number of cases are less, of course, considering if you go by the population ratio, and of course other details as well. But again, the point is that yes, the child marriage is rampant, as Lucky might have mentioned in the details as well, is more prevalent, as more rampant in developing countries. Reason being, awareness is not there. Even if though there is awareness, there are a lot of cultural traditional norms that are being I would say just that it's all for girls and women, and it doesn't matter what religion or culture you come from. It's really for every religion. From the work that we have been doing, in the end, when there's no logic, it comes to the religion and traditions, and that's where what they use to justify it for. So the point is, if we anyways want to make sure that with one world we have AI with all these amazing technologies and all these things that are happening, and on top of it, it's okay, Frank, you can leave. Thank you so much. Mm, we cannot hear you, but okay. But there's AI on one side, and there are these young girls on the other side who are still not going to school. The gap is just widening by the passing year, and we are struggling right now, and struggling is the word, to find a way that we can bridge this gap. Already, the policies that are being drafted and being approved and become a bill, they are there, they're not being implemented. And now AI is also another thing. So it's just that the gap is becoming wider and wider. And I feel like, what coming back to what Ganesh said, collaboration is the only solution, because